So here you're watching the Induced Sleep Endoscopy with this monitoring. In a 37-year-old male with history of snoring, choking, you can see he's breathing through his mouth partly. He's got a deviated septum on the left and turbinate hypertrophy. More than the deviated septum, turbinate hypertrophy is prominent on both the sides. His body mass index is 25, so he's not obese at all. He's not overweight. 25 normal BMI, and his AHI is 66. So very, very severe sleep apnea. Majority are apneas. As we understand, you can see his posterior part of the nasal septum is deficient, vomer is deficient. There are no adenoids. This is the inferior turbinate of the other side. Alright, so pretty large inferior turbinate. No adenoids. The salpingopharyngeal folds are can say salpingopharyngeal folds are also grade 0 or at the most grade 1. On the physical examination, his tonsils were large, palate was long, and the same thing you can see here. Its palate is collapsing. Now this is in the correct range, 70s, and we can see a complete collapse of the lower part of the soft palate, which is both anteroposterior and lateral, but majority anteroposterior. You can see both AP as well as lateral. And at this point of time, I'm trying to look at the base tongue and the epiglottis. So even the base tongue and the epiglottis is also collapsing. But this could be also, so this is certainly not Bernoulli's. You can see the base tongue is collapsing on the epiglottis. So this is secondary epiglottic collapse, not the primary epiglottis which you saw earlier. Now his mouth is closed. His mouth is still not open. I will still try to keep his mandible fully approximated to the maxilla. So I am now closing his mouth. Can you just hold the mouth properly? Only close the mouth. I'm trying to now close his mouth more forcefully, and still you can see the base tongue and the epiglottis collapsing. There is some lymphoid tissue on the base tongue. So obviously he requires a uvulopalatopharyngoplasty with base tongue reduction and glossopeglottoplexy. As we can understand that AHI of 66 could not have been, majority apneas could not have been only because of the nose, and therefore is referred from Indore. And his primary surgery would be palate surgery and base tongue and epiglottic surgery. We can possibly do some channeling of the inferior turbinates, but I would want the septal deviation is not too much, it's minimal, so that we can ignore, we can do some channeling. At the same time, a proper turbinoplasty would also help to a great extent, but then we have to pack the nose, which I do not want. So his primary surgery will be the pharyngeal surgery along with channeling of the inferior turbinates in the same sitting, so that we can, after doing the channeling, we can put the nasal tube and perform the palate and base tongue surgery. Thank you for watching.